Dr. Frank would entertain some questions if, or comments. People can go to the microphone.
Hey, Richard, great talk.
If
You were to prioritize quality metrics for prevention and behavioral health, given the, the scenario you've painted, what would those be?
This is like, this is Coles to Newcastle, right?
Yeah, right.
Yeah, no. Let me actually sort of appeal to Hendricks here a little bit by saying two things. One is, I think that you need broad measures that are indicative of a system generally doing the right things. I don't think you can go real narrow. The other thing I think that would be worth doing would be taking a more sort of, in a sense, tiered approach to quality measurement. So if you have real simple indicator, that if you fail that indicator, you then get a different level of scrutiny. So you collect more data. And for those who still fail after that, then you get an audit. And so it's almost like Bayesian in terms of you continuously update as you get more information about these guys. And I think strategically, I think that would be a really important frontier to figure out, because you need to do a lot of research, both methodological and practical, to figure out how to do that. But that would be where I'd go.
Okay, thanks. Can I ask one more question? I'll be quick.
You just did.
Sorry, David. I'll make it quick. But this issue around the amount of time it takes for the payoff from prevention is, to me, a really critical issue. Ron Kessler's data show that 75% of mental health issues begin under age 24. So, and in states, it's about 5 to 1 in terms of paying for the adult mental health system versus kids. How do we reverse that, and how do we make that case for the investment now, knowing that it's going to be beyond the term of most politicians?
Yeah. Well, two things. First of all, there are some high payoff things. Juvenile justice payoffs are very quick, a lot of them. And so anything you can do there sort of in a slightly older population pays off pretty quickly. And so you're seeing that. So New York City has done a social impact bond on exactly that. Well, you know that. But some of the ways that people are thinking about skinning that cat is to develop a set of indicators of strong progress. And so what you have to have is a state government that's willing to look down the road, capitalize, and say, what are the, if I know that you've made it over this hurdle, the expected value of getting that far is X, and we'll pay you some portion of X. And that way, you then start to, in a sense, capitalize the promises along the way, showing that you're kind of meeting very well-documented milestones.
Hi, Dave Brent, University of Pittsburgh. Great talks, all of them, including yours. 2 points. One, that I think we should also remember that behavioral health interventions can have an impact on physical health. And so that when we're looking for payoffs, we may be able to find them not in using measures that are more accepted. For example, maternal depression, pediatric asthma, emergency room visits, and the list is quite long there. And the other is just in terms of talking about social capital bonds. I don't know what about the idea of bundling bonds, where you have a mixture of something that pays off short-term and long-term, so that you can attract pool of investors and so that you get people to invest in the long run as well.
Yeah, let me react to your well, yes to the answer is yes, I agree with the second. Let me react to the first part of your first comment, which is I think we all have long lists of potential offsets on healthcare, on juvenile justice, on housing, etc., from good mental health services. It turns out that actually when you drill into those data very carefully, that is true, but that is true for a very targeted, narrow slice of the world. And if you're going to make that argument, then your programs have to be targeted that way, which then sort of brings you back to the clinical preventive services and the early intervention services a little bit more than it does the general public health things, because those are just a little bit harder to target. Although David Olds has sort of shown that you can target, but I'm just saying that in general, those types of arguments tend to favor that side of the house, which the good news is that's where we're putting our money in right now most aggressively. So that's a reason for optimism, and that should also guide the performance measurement a little bit if you're going to make those arguments.
Harold Pearl, National Institute on Drug Abuse. Hi, Richard. Great talk. And also a good panel earlier, too. Very informative and stimulating. I want to go back to two issues that you talked about a second ago. The dearth of quality measurement in behavioral health, and also the long time to visible payoff, and actually combine those two. And ask you to talk a little bit about the utility of developing some more proximal measures that we can see impact on early on, but will predict well the eventual payoff, and how those might be used in a social impact bond.
Yeah, I think that's absolutely right, and that was what I was trying to get at in my response to Kimberly's question. And I just think that that is absolutely the right way to do it. And some programs, there's a program right now in Fresno, California, that the county and state government are putting, and some foundations are putting money in, that is a targeted asthma intervention for kids, and involves a lot of stuff with housing and buying special vacuums and things like that. But because it takes a while for that to pay off, they've also come up with some proximal indicators. They're probably in a little bit better shape than we are in knowing what those proximal ones are that predict really well in the long run. But I think that's both the research and the practice challenge going forward, if we're going to use those animals.
Yeah, hi, Jeff Sugar from University of Southern California and Children's Institute in Los Angeles. Very provocative, interesting talk. Reminds me of, I think it was the first Clinton election campaign. The mantra, it's the economy, stupid. So we really need to look at those issues. But I'd like to just ask your thoughts on a related question to what Kim Hogewood talked about. These interventions that do require not always a lot of time, but often a lot of intensive upfront costs and service. And I'm thinking of my own experience trying to implement an MST program as an alternative to residential treatment many years ago. And it wasn't just, concern about the cost, because I kind of had that covered. What was the concern was the people at the institution where I wanted to implement it were afraid, because, well, I think they were really afraid for their jobs, but what got presented to me was, well, we've promised these people that they will get, so many visits by a worker in their home. And if you're saying that now will be assessed, and if they're doing well, they're going to get less service, they may get upset. I mean, it was absurd on the face of it, but I think that kind of thinking is out there. People expect this service, we expect to deliver it in this way, and we're challenging a lot of long-held beliefs in practitioners who've been in the field for many years and know what they're doing, or think so.
Yeah, I at the beginning, when I was planning this talk, I was trying to figure out, do I go into all the details of the problems that come up with scaling, or do I just focus on what I know? So now you've given me the opportunity to speak about what I don't know. But
always fun.
But I think certainly, well, change is hard, right? We know that, and changing and creating the conditions under which these things will take hold and you will have the workforce reoriented, because that's, you know, you're asking a lot of people to change the way they do business. And it's just not going to be new people that come in and do all this.
Right.
That takes a lot of work, and that's tricky, and it's not something that financial incentives, even though, you know, as an economist, I agree with Kelly that money is a driver and that people will often figure it out when you set the reward systems up. It's not automatic, and there's a lot of kind of pain and ugliness along the way, and I think that's the fact. And I don't think we understand exactly what all the steps we have to take to get from here to there once you've set the financial incentives and organizational structures up correctly.
It seems there should be some way to incentivize the people at the front end, at
Yeah.
at the intervention level.
Isn't that what they call implementation science? Yeah, right.
I'm David Hawkins from the University of Washington, and I really like these three distinctions that you made in the types of preventive services, and want to ask you about a potential thought about how do you bring some of these public health access kinds of universal preventive interventions more into perhaps clinical preventive intervention services. And I give you an example. We now have a number of parenting-focused interventions for parents of children just entering adolescence. And follow-up studies of these in controlled trials have shown that they have an effect on initiation of not only substance use and smoking, but also delinquency and even depressive symptoms. These have been traditionally offered in universal settings in communities or in schools, et cetera. And yet we know that parenting interventions, when people are encouraged to participate in them in their school, et cetera, in the community, they say, I'm not going to do that, that's for bad parents. And yet we think that if a pediatrician or a family practice physician said, your child is going to be 12 or 13 years old, now's the time that you can learn the parenting skills that will reduce the likelihood of smoking, et cetera. It just seems like if that were if clinicians were referring, pediatricians, primary care physicians were referring people to those kinds of services, the legitimacy and the stigma would both be changed, and we might have a much greater take-up of those kinds of services. And yet, for the U.S. Preventive Task Force to say those are A or B ratings, it requires some kind of screening process, et cetera. And so it seems that we're kind of operating in cross purposes with ourselves. And I wonder if you could talk about that.
There's the hard question. Okay. I don't usually think this quick, so I'm stalling here. No, I think the issue is you have sort of two extraordinarily difficult things kind of bumping up against each other. Our reimbursement systems, our referral systems and things are driven by sort of a medical model and a sort of insurance-based model, and they reinforce each other. Now, I don't think there's a problem in having pediatricians refer, and probably lots of people would agree that that's a good thing. It's making sure that, one, in fact, they view it as their job to know about those things so that they can refer, and that probably means figuring out a way to incent that. On the other side, you could probably just end run that whole side of things and say, look, these are public health interventions. Let's set up institutions that actually do that. Let's fund organizations that reach out to the pediatricians, do training, sort of connect to the pediatricians and do it that way. Both of them are difficult. And it's a matter of where do you think you have the most leverage?
Maybe we could follow Kelly Keller's suggestion and see if we could create a business model in which the family practice or the pediatrician or other clinic services might be able to provide those services at a reasonable enough cost that would be beneficial to them.
Yeah, we have an experiment. I mean, the Medicaid health homes are supposed to do some of that for, not so much for preventive services, but for adults and children with multiple chronic conditions. And they're supposed to connect people to housing, to other types of social services, nutritional support, and things like that. It'll be interesting to study that very carefully to see what levers they use. In New York State, for example, is creating an incentive related to their health homes and things that tie payoffs to housing outcomes. And I think learning from those is going to be an opportunity, and then we'll know which way to go.
Thanks.
So we are out of time. I'll let you ask your question since you've stood there patiently. Depending on how long the
You
answer
won't let me
is.
answer it.
And then we'll have a break, and then at 10:55, we'll go to our 3 breakout groups. And Mary Jane, or Morgan, maybe you can tell us where those are going to be located, but let's hear the question first. Let's hear the question first.
Bill, thanks. And Richard, thank you for a terrific talk. I want to link, again, Kelly's notion of the business model with your notion of social investment bonds and raise the question, at least in my mind, in the past, when we were developing the Children's Health Insurance Program in Pennsylvania, we relied on a syntax. We couldn't get the deliberate investment in what was shown to be a value, profitable cost savings, and we relied, and I'm not even sure, you're the economist, whether this is the correct term, a regressive approach to investing in something corrective and positive. It almost sounds like relabeling some of this gives a different incentive and invites the entrepreneurs to determine if there's evidence for the value of the investment rather than the transparent investment that's been there and it's confronted us, and for reasons that are still very complicated, largely the word political and economic, we don't fund those things. We don't take the responsibility as a community to invest in them, and we use other mechanisms. So I'm curious what your reaction is to our history of using regressive syntaxes as a pre-social investment bond activity.
Okay. Well, they really, I don't think that these are just semantic differences. I think the only thing more dangerous than saying you want the government to spend more money is to say you want to use taxes to support it. And so I think that it's very tricky to do that. I think the thing that makes the social impact bond attractive is that these are sort of voluntary associations by private investors, sometimes encouraged by foundations which are tax advantaged in their own ways, and there are some tax rules that actually encourage them to be involved in these types of ventures. And so I actually think they're actually different mechanisms, and solve a political problem really differently. And they're, at the end of the day, they're less regressive too, but more limited in how you can use them.
So let me ask you all to thank Dr. Frank for this extraordinary talk and the extraordinary responses to the questions. So thank you.
So I just have to say, as a citizen, it's so inspiring to get to come to a meeting where you have federal officials like Dr. Frank, like knowing that Brian Samuels had been leading ACF, and this afternoon we're going to get to hear Fran Harding, Charles Collins, again from federal agencies, that we have this leadership gives me hope, and that the very difficult problems that we're challenging, we're going to make it through. So you get a break. Now the real business, everybody networking, figuring out solutions, beginning the work of the discussion groups. You're going to come not back here, but to 3 different sector groups. If we've combined criminal justice, juvenile and criminal justice, and child welfare, and they're meeting in this room, and Larry... Okay, and so Morgan Ford is going to tell us where you're going to come at 10:55, and I'll be the little shepherd out there herding you all into your rooms at 10:55. So she's quickly going to tell you so you can talk to your friends as long as possible.
Okay, so just a couple of things about the breakout groups. Included in the meeting materials on the registration desk outside of this room was a list of the breakout group assignments. If for some reason your name is not on that list, you're welcome to join whatever group you'd like. All of the meeting rooms are on this floor, but on the opposite side of the building. So when you leave the registration area, turn left and walk down the small flight of stairs and straight across to the statue of Darwin. And just before him, you can turn left if you're in the Child Welfare or Juvenile Justice room, and up a small flight of stairs and right for the healthcare and schools groups. And then at 12:30 p.m., lunch is going to be available right outside here in the registration area, and then we'll reconvene in this room at 1:30 for the afternoon presentations. Are there any questions about anything? Okay. Sure. The members of the forum who are on the ACA Collaborative over lunch will meet at one of the tables in the registration area.